Recently I was kind of just doing some self-evaluation and like kind of some self-reflection on me as an instructor and what I could be doing to improve the way that I teach. And then I just kind of started thinking about, you know, people I see in the field, like why are they at this point like they're making their mistakes? Why is their patient assessment and stuff flowing this way? Then I started realizing that, I believe that some of those issues are caused by lack thereof in initial education. So then I kind of just started thinking about, like, well, where does initial education fail us? And just kind of came up with some ideas on things where I think that some initial education programs are failing. Even though the goal of an initial program is to teach an entry level provider, I do think that even some of those things are not preparing them efficiently to be entry level. Welcome to Profess EMS, the podcast dedicated to educating, training, mentoring, and inspiring EMS educators and providers alike. Whether you're looking to grow as an educator or prosper as a provider, sit back, open those neural pathways, and let's get to it. One of the first things that came to my mind was that programs are only teaching about the job, not the career. And like an example of that, of employees not realizing that once they've obtained a certification that they have to recertify that, or what it actually takes, or what they might need to get a job at an EMS agency or a fire department or wherever. That the class they were in only was teaching them things of how to pass a test, not how to begin a career.
I think that really is the kind of the war that we're fighting when it comes to education is that educators are stuck in this cross paths of what they really need to know to be a good paramedic or EMT versus what they need to know in order to pass a test. And unfortunately, it's going to kind of, break the ice on what my one of my favorite things to talk about when it comes to initial education is it's going to break the ice of what I want to talk about next is that usually, especially in EMT school, it's taught to pass the test. And it's because of how fast EMT school is and how short it is. And so you don't really have the time to teach them everything they need to know from a knowledge perspective as to how to be a good EMT. At the same time, get them all the information they need to know in order to pass the test. And so you have to choose the path because you're so limited on time. And I think that that is a really good point is that which one do you choose to go down? And unfortunately, you can only if you want to split it up, you can maybe make it 70-30, but you got to choose which path you're going to choose. Whether it's going to be exam or if it's going to be how to be good. Now, um, I think that's one of the biggest places that, and it's not just a US thing, like being in Canada and working with a lot of paramedic colleges, we see the same thing here. Time isn't as much of an issue, but we certainly see programs teach to the test as opposed to teaching to operational abilities of a paramedic because they think that they're going to learn that as they go, which they will. But in truth, we're trying to serve these students, and the reputation of those colleges is quite strongly tied to how good these students perform when they become paramedics. And I think paramedics on the like when they realize what college you go to and then you have a string of students that are all very similar in their lack of abilities, it tends to build a reputation for that college. And that's something that, from an educator standpoint, is maybe something to think about is that yes, getting past the exam is important. There are tools that you can get, selfish plug Master Medics, uh, that will help with passing the exam. Um, so that way you can focus on the operational ability of a paramedic from a teaching perspective. And so that might be the best way to go about it, is that use the tools that are proven in order to work with the exam portion of it, so that way you can focus on what's important, is creating good EMTs and good paramedics. And so I think that's a really big part of it. And which leads me into my next point, which is initial education is too short in almost
Yeah.
every concept of the word. If you look at successful programs and successful paramedic organizational like successes, one of the biggest ones that you can look at, and the most successful ones you can look at, is the Australian model, and where there is a clear educational path um, from diploma, like a 2-year program, to a degree, to a master's, and your knowledge continues to build on top of that. And so I understand that there's a shortage of paramedics in the North America, and that elongating the program significantly impacts the hiring process of it. I get that. But when it comes to initial education and like what's going to make paramedics better, the evidence is so heavily in the side of an actual sound structural education pathway. It's not it's infallible that we haven't even moved that way, except for the fact that it's been blocked. Um, yeah, so that's my two things that I wanted to talk about when it comes to that, and the speed at which those things happen.
Yeah, totally. So another thing is, I think where initial education doesn't necessarily fail, but it doesn't really help is, with accreditation and whatnot, you have to have all these boxes checked, and there has to be some type of measurement to say that yes, this experience in a clinical setting would count for a patient. So, that generally requires that, hey, as a paramedic student, while you're in practicum, run the ambulance, that a patient assessment or that call you have to count. Say if you have to have 50 patients within your paramedic program, that for that patient to count, you had to have given a medication and started an IV and those things. So the students are so crammed on time to get all these things in too short of a program, that they so much emphasize, "Okay, I got to make this call count. I got to make this call count." So think back as a student, um, and this will live in my head forever. That as a student, I was so focused on, I got to get an IV. I got to get an IV because I need to make this call count. That it was one of my first shifts as a paramedic student. We went to a structure fire with injuries. A woman had been pulled out of this fire by a neighbor, and she was unresponsive in the backyard, barely breathing. Uh, Me, an EMT, and my paramedic preceptor all got up to her about the same time. And what's the first thing that I did? Try to start an IV on a woman who was unresponsive and barely breathing. And then, I mean, even the EMT was like, "Ben, she's not breathing, bag her." I'm like, "Oh, yeah," but I wasn't thinking about that because my mind was so tied into, well, I need this to count. If I ventilate, that doesn't count. So I'm so focused on making those calls count that there's that emphasis on, getting the skill to check that box. That I think there needs to be more of a flexibility in those things to say, hey, this was a great experience of a call. So even if that patient, if I'd only managed the airway, would have been such a great learning experience, but I got so focused on the IV that, and I see that in brand new paramedics, that they get so emphasized on still wanting to make sure that I'm a paramedic. I have to start IVs, or I've got to give a drug, and they'll skip over the very basic things.
Mm.
Um, so I think that is one thing that kind of almost sets them up for failure is they're getting so rushed, so pressured, and like you said, it's in such a short period of time. They feel that pressure and that urgency just to get the boxes checked so they can get completed.
Mhm.
So
Yeah, I
with
remember one of our competencies that we have is to get a manual blood pressure palpated and get an auscultated one. It's just like you need those opportunities sometimes that it kind of supersedes everything else. And it's a check in the box that has nothing to do with what's actually going on with that patient. You're so right. And sometimes we miss the greater lesson in that patient. And I think that's very true, is that we get so like, I need to do this so that way I can pass school, as opposed to I need to actually work as a paramedic, or like operate as a paramedic in this environment, and then the skills will come. It's a hard lesson to remember, especially when you're so competency focused. um
absolutely.
yeah.
And I think that some of that could be resolved by better mentor training. And I
Hmm.
mean, I can point the finger directly at myself because in my time as a program director, I really wish I could have improved the mentor training. But without making excuses, our program did cover students across 6,000 square miles. So trying to be able to get more of an elaborate training out for mentors was really, really, really hard.
Hmm.
But then the only goal was that, hey, once you get the students in, you start teaching them the right ways and teach a student how they need a precept eventually, or what an ideal mentor preceptor should be. Eventually, those that you're training will spread the knowledge for you. But
Yeah.
yeah, I think it's these new medics out in the field are like, oh, I got to get an IV, I got to get an IV. And they're so excited to use all their skills that their primary assessments and secondary assessments become lacking.
Hmm. Definitely.
And then the concept of skills, another thing, this is a small soapbox of mine, is, within class and evaluation, there's always skill sheets, right? Well, from an educator standpoint, a skill sheet is a rubric. A rubric is designed of how you will measure and how you will grade something. That's what that is for. But these programs are continually handing out these skill sheets and say, learn this, learn this. And then they come into a station and they just start rambling verbatim what that skill sheet says without just doing it.
Hmm.
Now, I understand that there is the concept in education. If you can think about it, if you can talk about it, that there is a lot of cognitive research that shows that if you basically visualize things in your head or talk through it, that carries over to walking the walk as well. But when you get into these skill sessions and we're making these students study a rubric is failing us. They don't know what they're doing. They just know an order of how to do things. And
Hmm.
it's not that simple. I mean, it makes it more simple than like an IKEA instruction manual. But however, that's not what that is for. That is for us as an evaluator to make sure that they have hit all of these items and sometimes in a certain sequential order, but it's a rubric, it's an evaluative tool, not a not a instruction manual on what to do.
Hmm. I can't speak on those because that's a national registry
Yes.
rubric thing. So I never was exposed to those. We were exposed to something similar from a primary assessment tool that you had to hit them all, and that you got like a -1% if you missed one thing. And so the idea was like, memorize this primary survey tool and don't miss anything, because then it affects your mark, which doesn't really create any competence per se, right? It doesn't. You're just verbalizing things in order to make sure you don't fail. And then there's like the critical interventions where if you don't hit them, then you lose 10% of your mark, or in some cases 25% of your mark. and and then you fail that scenario, you fail school. Um, so that was it was an ineffective way to really test what we're supposed to be testing, which is competency. But it was the tool that we had 10, 12, 15 years ago to test competency. We didn't know how ineffective it truly was at the time. But anyways, it's we're seeing now that it's not a beneficial tool in testing and training competency, but we're still seeing it used in school. And so I hope that we start to move away from these outdated approaches of just memorize this sheet and you'll be fine, because that's not what we're supposed to be training in paramedic school. It's supposed to be how to create a competent skill provider, and memorizing sheets doesn't achieve that. It can
Not at
help
all.
in the beginning, but it doesn't achieve the goal.
Yeah, those are used to definitely develop or establish a foundation.
Hmm.
And an accreditation and registry are moving towards all of that, as they've recently here just in this month got rid of their psychomotor testing,
Yep.
that they're using it now and evaluating that, hey, we're using this and designing it as building blocks and progressive assessment and continual evaluation throughout programs. So I mean that trend's going that way. I mean, and we see it in all the other healthcare fields too, that everything in healthcare has went away from, well, let's just make sure you can do the very basics at the end rather than continual evaluation throughout. I mean, it goes for nursing, respiratory therapy, all of the major healthcare disciplines. We're seeing that now, that it's all embedded, built in the program of, and I like your analogy earlier of like the scaffolding approach, like building a layer, going up to the next one, and so on.
Okay, I got one last one that we might talk about for 10 minutes here. Um, and I think where education is failing us is a reliance on done for you systems. And um, it's not that a done for you system, I'm not going to name any names, but it's not that a done for you system can't be a beneficial tool for an educator, but the key to using it properly is altering it to the needs of your school and your program and your students, because the design of a done for you program is effectively the absolute minimum of what needs to be achieved. And so if you are only using a done for you product and you're not altering it, you're not enhancing it, you're not expanding on it, then you're only providing the minimum of what is expected of an EMT or paramedic. And so I think that is a big, I don't know if I want to call it a failure. It's a landmine that you want to avoid, is when you're using products such as those, and we have one as well where a in effect a done for you product that we heavily encourage that you put your own flair into. And I'm not just talking about ours. I think that if you ours, you also will step on this landmine. But any type of these products, they need your own flair. They need your own design. They need your own altering in order to be effective in producing competent EMTs and paramedics. Because it's your job to teach above and beyond the minimum expectation.
Oh, absolutely. The all those canned products, I mean, like it's fundamentally it gives you a starting point, right? And I'll make the analogy to I'm an avid motorcyclist and mountain biker. That hey, I could go buy a super nice mountain bike, and I pull it off the rack, and it's the current market in the U.S. on mountain bikes is nuts. So you've bought a $6,000 mountain bike. Yeah, that is great product. I've spent a lot of money on it, so it better be great, right? Well, it is, but when I take it off the shelf, I still have to set the suspension up, adjust the pressure in the tires, make sure I have the right kind of tires, that the bars need adjusted, the seat needs adjusted, that the brake levers need tweaked to my hand positioning. There's a lot of fine tuning that goes into that. Yeah,
Mhm.
you've got a great product right off the bat that can carry you through, but you still have to put your own touches on it to make it comfortable and fitting and accommodating for really what your purpose is going to be. You can't go get a brand new dirt bike and then expect it to be able to race enduro and cross country and motocross and supercross all at once. Those are four completely different elements that require modification and adjusting and fine tuning. Yeah,
Mhm.
you can, it's the same concept, same, there's a frame, a motor, wheels, tires, brakes, but all those things require adjusting and tuning depending on what your end goal is.
Yep.
All right, and the one I saved for the last, this is my big soapbox. All right, so and I share yours with you too. That yeah, a canned product isn't meant to just take off and serve. It's not like that. The canned cranberry at Thanksgiving, where you're supposed to open the can and just dump it on the tray. Okay, that stuff is not that simple.
You don't do
Right?
that?
Even I mean, yes, we do. Yeah, yes. But should we? No. Should every meal be that way? No. We gotta take the turkey, we gotta baste it and season it and fry it and do all those fun things and make it taste good. Okay. So, but yeah, they are meant to have your own flair and stuff added to them because not every locale is going to do everything the same exact way. The interventions and scope of practices are different, so it requires some significant supplementing. Like, say, in my state, EMTs in my state can do their scope of practice is equivalent to most other states' advanced EMT. But however, if you took a canned product from one of these companies and just said, "Hey, here's all of the slides and the quizzes and information you need to teach an EMT class," that is the bare minimum objectives that are measured for national registry, um, or the locale. But that's not going to cover all the other additional things that an EMT in my state can do. Now, granted, they're testing for the national registry, but still, the ultimate goal is there need to be a state EMT and be able to function as EMTs do here. So that requires a whole additional supplemental um, program to be put into that. So there's work has to go into it. You just can't open it, put it out there, and let everybody dive into it. All right. So the one that I saved for the end, and this is one of my biggest soapboxes, and this goes back to those skill sheets of BSI scene safety. It gives me such a headache for the fact that we as evaluators are going to let somebody come in. When we're doing skill testing, they come in, they have to look at us and say, BSI is my scene safe. Well, I sure as shit hope so because you're already at the scene. Okay. On those skills, she's talking about BSI, scene safety, mechanism of injury, additional resources needed, number of patients. That sounds great. You should have all that figured out far before you get to a scene. As soon as generally before like you're in transport or responding, you gotta have these things figured out. So the fact that we're doing this testing, people come in, throw their hands up in the air and say, "Oh, BSI, scene safe." Well, did you evaluate it? Did we discuss it anything before? Are we really teaching anybody how to evaluate if the scene is safe? And a lot of simulations and scenarios that we would do, I would make students go into a room that the door was closed, and I would have like loud noises playing behind the door, or dogs barking, or people screaming, and see if they just take themselves into the middle of it. So, how are we actually testing these students and making them evaluate is the scene safe? So, what I would generally do with some of mine is we would set up a scenario in one room, and then I would meet with the students who are going to go through the simulation in another area, and I would give them dispatch information and let them talk through that. And then we would like walk and talk like they're responding to the call and be giving them information and let them be thinking about those concepts of, oh, I shouldn't even get close to them now because the scene's not safe. Because inevitably 99% of the calls we respond to, it's a, well, hurry up and get there kind of situation. And we're not thinking about those things. But the fact that we gotta, oh, you came and I told you to go ahead and come into this room where we're gonna do scenarios and you didn't ask me if the scene was safe and I fail you, that is a load of shit. Okay. So that is not teaching them anything besides that they have to say these things as mouth vomit, and then they're never truly considering what a safe scene is.
It's funny that you have a big pet peeve. This might make you have an aneurysm, but those two things, BSI and scene safe, if you didn't verbalize those in our Canadian exam primary surveys or like scenario outlines, if you didn't say those things, literally verbalize them. If you just forgot about them, you fail the exam. And
Oh, it's same way here too. And
it's
it's I never understood that. It's like, hey, I'm your proctor today. Come on in. Here's your scene. And they give you all the information. And then you're supposed to see, is my scene safe? Well, you should have made that determination already.
yeah.
Yeah. So why are we not evaluating that we give them some type of objective to see if they like make the scene not safe and see if they've detected that it's not safe. And
Mhm.
then if they didn't catch, we're looking them for them to catch, hey, this patient has a pneumothorax, but we're not expecting them to self-evaluate that the scene is not safe.
Funny things that we still to this day do that we haven't learned.
Yeah, it's such a pain. And yeah, it's and going from like an administrative side of things, I have calls that are reviewed every time, like multiple times. So it's like, how did you even get yourself into this predicament? And
hmm
they're so strung up on just that, you know, adrenaline rush that they're just not thinking about it because we've never really taught them to evaluate, is the scene safe or not.
hmm
I remember there was a student one time, and it almost got myself in a pickle with this, but I was trying to teach them the means of evaluating a safe scene, and we ran a scenario, and I was, the husband of the female patient, and I was standing there, and I had a fake gun. Because in America, we train on guns all the time.
hmm
So, so I'm standing there with this firearm and I'm expecting them to like think about retreating. Well, the next thing I know, this student who's about 6'5", 280 pounds, manhandles me. I mean, just dove at me, yelled, and just, I mean, I couldn't do anything. Just like was just wrestling me to the ground and was not expecting it. And then I did know at the time, and I was like, "Hey man, should you really have done that?" He's like, Sir, I'm sorry." He said, "I was, in the military for several years, and I was just trying to neutralize a threat." I'm like, maybe I should know my audience just a little bit better.
hmm How humbling is that moment? Like, boom! Like, oh my gosh, I literally cannot move because there's someone
Yeah,
twice my size on me.
yeah. The only thing I could do is like I was able to kind of get my arm up and like hold it like it was beside my head, and like, I shot you, let me go." It was very much like I'm scared, put me down. Uh,
You're just going back to
yes,
like grade school when you're playing with your friends with water guns. Like, I shot you, you're dead.
yeah, yeah. You're out. You're out.
Yeah.
Yeah, that was very much how it was. But he still didn't want to let go.
Oh
Yeah,
man.
because his brain just switched gears. But
Yeah.
yeah, of truly trying to evaluate, do they have BSI on for the level they're responding to, and is the scene truly safe? Let's
hmm
start teaching them to evaluate, putting some type of simulation in those scenarios for them to truly evaluate if the scene is safe or not.
hmm